Hello, Stroke Busters! Welcome back to another episode of our podcast dedicated to exploring the latest in stroke research, treatment, and stories of resilience. I'm your host, Amy Quinn, and today we have an incredible guest joining us, a true expert in the field. I'm thrilled to welcome Stuart Fraser, Assistant Professor in Pediatric Neurology and the Director of the Pediatric Stroke Program here at the Stroke Institute. Dr. Fraser joined students at the McGovern Medical School for stroke grand rounds, and we asked him to stick around for a follow-up interview with our stroke fellow, Carlos de la Garza. Pediatric stroke is an area that often doesn't get the attention it deserves, so I'm excited for this episode to shed light on the advancements and opportunities for improving outcomes. It's insightful, refreshing, and a great listen for students and trainees who, for all the right reasons, get a little nervous when they hear anything relating to pediatrics. Dr. Fraser has some great advice for them, so let's dive right in.
Okay. Hello, everyone, and thank you for joining us today. I have the pleasure of talking to Dr. Stuart Fraser, pediatric and vascular neurologist at UT Health Houston. Dr. Fraser, thank you for joining us today and taking this opportunity to talk with us.
Thanks for having me.
Absolutely. I've had the opportunity to work with you, and by work, I mean being coached through a pediatric stroke consult. Basically, as an adult neurologist and soon to be vascular neurologist, pediatric patients have always made me and most of my colleagues somewhat nervous. So that being said, do kids have strokes? If I get a page in the middle of the night that says pediatric code stroke, what's the possibility of this being the real deal? How concerned should I be?
Good question. So, yeah, I will repeat my baseline facts that I say forever, and it's that, yeah, kids do have strokes. Believe it or not, it's the most common cause of hemiparetic cerebral palsy. So about 1 in 1,100 children when they're born will have a stroke. And then it's maybe one for every, out of every 20,000 each year after that, for the first 19, 20 years of your life. So yes, they have strokes. It's the 9th most common cause of death in pediatrics. And it's an uncommon disease, but it's not technically rare. So it's something that I think stroke neurologists, wherever they are, they do get asked about, and knowing a few key facts can be helpful in your practice. And then that feared pediatric code stroke page, what is the chance that it is that it ends up being a stroke? It depends on where you are, but the take-home number is usually about 1 in 4. 1 in 4 pediatric stroke alerts in big hospitals end up being strokes. And, of those, there's a pretty decent chance that it's a large artery occlusion, just like in adults, when kids have an acute ischemic stroke, about 1 out of 4 ends up being an LVO.
So in your experience, what's from the point of view of the emergency room, or say a paramedic,
Yeah.
What's the first symptom, or what's the most common symptom that you've noticed that they should be concerned about?
Awesome. Yeah, that's a good question too. So, and people ask, and I think that what people worry about is I think pediatric providers will often say they're not just little adults and they present very differently. And I tell people that though that's true, if you're coming from the baseline of a neurologist, it's okay to use that baseline and just keep a few modifications in mind when you're trying to think about kids with stroke. So, okay, good question. Yeah. So, what is the most common symptom that someone might see, or an ED physician, or a paramedic, or a vascular neurologist? What I tell people generally is that though it can be harder to get that information out of a child than a previously healthy adult, the presenting symptoms from stroke actually are, for the most part, fairly similar. Hemiparesis, sudden onset, unexplained altered mental status, dysarthria, inability to walk, kids can have all of those things, and hemiparesis is actually the most common cause for which a code stroke is called. One of the big differences is that kids are more likely to have a seizure at stroke onset, or at least be coded as having a seizure or diagnosed as having a seizure at stroke onset than adults. And this can sometimes put them on the wrong diagnostic pathway. So I tell people that someone with a new seizure and a Todd's paralysis afterwards, and they've never had a seizure before, that's enough of a reason to put them on, to prove to yourself that they're not having a stroke with advanced imaging as quickly as possible. If they recover while they're on the scanner, that's great. But a child with a new onset hemiparesis in the setting of seizures, never had this before, that's something to take very, very seriously. The one other thing I'll say is that little kids, so neonates, infants under 1 year old, or sometimes even 2 years old, can be very likely to present with seizure and encephalopathy, and those can be difficult to diagnose. But generally, for ischemic stroke anyway, kids under a year, we don't put them in the intervention window in terms of thrombolysis and thrombectomy. It's been done before. It just is, I think, a much tougher sell than on a 5 or 6 year old.
So is it fair to say that most of your patients who are within the neonatal period will be inpatient consults and not necessarily somebody that's brought in by parents or something?
Yes, absolutely. So almost all of them are inpatient consults. The story is the child will be born. Oftentimes they'll have a rough birth from something, maybe a maternal infection or some heart rate changes near birth, and they'll appear a little bit floppy, and then a few hours later we'll start having seizures. And usually that's what instigates them getting an MRI done and us diagnosing stroke.
Oh, understood. So one of the things that might help us out as or as adult neurologists or vascular neurologists is if you can talk us through what your thought process is once you get a call from one of your fellows, once you get a call from one of the vascular neurology fellows, or even if you get a page and it just says that dreaded, or at least dreaded for us, pediatric code stroke. What's your thought process like? What are you looking for? What are we supposed to be looking for? What are we supposed to be thinking about?
Awesome question. So I use that adult stroke neurology or just stroke neurology training as my baseline, and then I add a few caveats to things to try to keep myself in the same sort of framework that I can do hopefully the best job possible. So if you get the first phone call, the first question I'm always trying to answer, which is the same in the adult stroke world, is this patient a thrombolysis candidate, and are they a thrombectomy candidate in terms of their initial presentation? So the first thing is, when do the symptoms start? How severe are the symptoms? And then the third, how old are they? Because really under 2 years old, it's very difficult to push for something like a thrombectomy or thrombolysis. And actually in the protocol we wrote for our hospital, we don't consider it under 2 years of age. So if someone calls and says, hey, I have a code stroke, they have XYZ symptoms, the first thing I ask is, how severe are they? And NIHSS, if the person was able to do it, or just if they are having trouble getting them to cooperate, I just say, what do you see? Are they moving their right arm at all? No, it looks like at baseline they're not. Okay, when you pinch it, does anything happen? If the answer is still no, then you think, oh, that sounds pretty severe. And then after that, the next question, if it seems like they are a intervention candidate or potentially an intervention candidate, is how do I figure out if they have something that's intervenable? Can I get them to the MRI scanner immediately? And that's based off, one is would the child be able to sit still without anesthesia? And a lot of times the answer is yes, if you keep reassuring them. And two, if they're, do they have any contraindication to it, like a pacemaker or hardware or something like that? And if not, then we go, of course, to a CT and a CTA. And the big thing we're trying to rule out is large artery occlusion. That's the biggest, most intervenable problem a child could have, and your biggest chance to make a big difference. So the big thing I'm trying to do when I get those calls is trying to rule out large artery occlusion. After that, then we start thinking about those three sort of problems with stroke that we had talked about before. Okay, we were or were not able to intervene. Now I'm trying to diagnose stroke, yes or no. And with us, usually MRI is the way that we make that that distinction one way or the other. So first is intervention, and then yes or no, and then after that, if we're not sure if they're having a stroke, you're trying to find out ultimately, is this a stroke, yes or no? And MRI is usually the way that you do it.
Understood. And that's very helpful. My next question might be a little bit loaded, I guess.
Okay,
but
I love that.
Fair enough. But I think it's something that will help not only us as fellows, but residents as well. If I'm not mistaken, you were on service on the adult side a couple of weeks back, maybe a couple of months back.
Yeah.
What have you noticed in terms of how residents and how fellows approach stroke from the adult side versus the pediatric side?
Oh, wow. Well, one would be with, I think they approach adult stroke with a lot more confidence. And that comes with experience, I think. Adult stroke is hard. It is. There's a lot of considerations, and you have to make big decisions to the best of your ability, trying to save as much brain as you can, as I like to say, because it's someone's life. And we all want to prevent disability as much as possible. That is our goal. Because in the adult world, you see it over and over and over and over again, I think people are a lot more confident. What I tell people about PD stroke is it actually, I would say it's not harder. It's just you haven't had as much practice. And so that's where I tell people it's okay to lean back on what you know already and use that with a couple of adjustments and framework to try to help that child that you're being consulted on. Again, going on those same pathway. Okay, is this person an intervention candidate in those two ways that I'm concerned about, yes or no? And then what is my final diagnosis, vascular or not vascular? If you can do that as a stroke neurologist and not a child neurologist who has to figure it out if it's not a stroke what to do, you are ahead of the game, and you will be really helping out when you are called on to provide your input on these difficult cases.
And I think that little phrase that you mentioned, where we should lean back on our training, even though we're dealing with patients who we don't typically see.
Yeah.
And that being said, that code stroke at 3 a.m. that ends up being a pediatric patient. I mean, people are half asleep or whatever, and you get there and you see a kid. I mean, you start to freak out a little bit. But at the end of the day, if you're able to lean back onto the training you already have, I mean, you could at least make the determination if the patient is a candidate for any kind of intervention within window.
Yeah. Yeah. And I think as long as you set those reasonable expectations for yourself, you can feel like you're doing the right thing. When you run it, I always joke, there's a reason they call it the nervous system, because it makes people nervous, and pediatric stroke is something that makes people nervous. But if you step back and remember, all the things that then it becomes easy to use your resources to try to figure out how to get the information you need to help that child so everyone else can do what they have to do too. So if there's concern for hemiparesis or not talking the way they normally are supposed to, and you can't remember because you don't walk around with all these things in your mind, oh my gosh, how is a 4-year-old supposed to be able to speak in fluent sentences? How much are they supposed to say? How many words are they supposed to know? You have a secret cheat sheet that is always with you, and it's okay to turn towards them, and that's the parents or the caregivers. If there's concern for language not being normal and you can't remember exactly what normal language is, you turn towards that mom or dad and you say, Mom, is he speaking less than normally, or does this sound normal to you? And if they say his voice sounds funny, that counts as dysarthria. And if they say no, he's not saying any words, that counts as aphasia. And you can do simple and you may be wrong and they were just crying and didn't want to talk to you. But it's okay to raise the alarm so that you proceed to the advanced imaging that you need.
Absolutely, and that's even more helpful, just in the assessment, because I mean, in the adult world, we'll turn around and ask the family, "Oh, do they sound normal?" or something
Yeah.
to that
Yeah.
extent. But
Yeah.
it's probably not something we had thought about within like language development and all that.
Yeah.
And then changing the subject matter a little bit, you mentioned seizures as a differential diagnosis in patients, but what mimics should we be aware about? What role do patients who come in with a history of sickle cell disease or some kind of mitochondrial pathology?
Yeah.
What advice can you give us from that perspective?
Yeah, that's a great question. So, um, and you actually kind of delved into risk factors in a way that I really like. So, I'll start with this. I'll talk about the big important mimics. Seizure is one, and at our hospital, about a quarter of our code strokes end up being seizure, and that's fine. You get a stat MRI for your seizure, no big deal. There's no harm. We're okay with that. Uh, and as a stroke neurologist, once you've ruled out stroke, you can back off and say, hey, this looks like seizure. I will defer to pediatric on dosing and medicine and what he needs next, and that's it. Other mimics include complicated migraine, which I think in teenagers, adult neurologists are pretty good at diagnosing in my experience. And of course, at the bottom of your differential, but we do see it fairly often, would be things like conversion disorder or functional neurologic disorders. Of the serious mimics, ones where uh, this could potentially be a big problem if you treated them for stroke inappropriately and when they weren't having one. We think about methotrexate toxicity. So for the residents, this is an on your boards and will be in your life sort of thing. People that receive intrathecal methotrexate for their cancer treatment can present with focal neurologic symptoms, hemiparesis, and it's very, very important to get that history of medical problems from a code stroke patient, particularly history of cancer if they just got cancer treatments through a spinal tap, because you don't want to give that person thrombolysis or because if they just got a spinal tap. Other serious mimics are encephalitis. I've seen encephalitis present acutely, but probably the problems was going on for a couple days. And the myelinating disorders, same thing, can present with sudden onset altered mental status or something like that. And a CT usually won't be good at helping you diagnose those things.
Well, that's very helpful, actually. Something we should really consider. And jumping off to the interventions, what's your opinion on TNK specifically for pediatric patients? There's this big push, and all the big centers are now doing TNK for the adult side. But how about in the PD side? Do you like TNK, or do you prefer just doing alteplase? What's your thought about those medications?
Awesome question. So TPA, if TPA specifically, if properly administered to children who have acute ischemic stroke and no contraindications, is probably as safe as in young adults in the same situation. And we're getting that from the Tipsters paper that was published several years ago. That comes with the caveat that there's a lot of unpublished cases out there of thrombolysis being done in pediatric patients where it might have been outside the window, or they had a contraindication like active malignancy or something like that. And they did have bleeding complications, and people don't like to publish those things. So I think that TPA probably has a record of being safe in kids, provided you do it correctly. And what I define as correct is the definitions they used in the TIPS trial in the 20 teens that we had talked about in Grand Rounds. TNK, we have, in terms of safety data, a recent case report out of WashU, some text messages I have received over the past year or two from anxious adult stroke friends that I've made over the years who asked my opinion, and we talked on the phone. And we'll have a debate on it soon at ISC this coming year. I would believe that it is probably as safe as TPA in kids, again, if administered correctly. The one thing about TPA as compared to TNK is if you're giving it to a kid and you realize your diagnosis is wrong 20 minutes into administration, you can stop it and probably lower their risk. And in TNK, you can't. And I talk a lot about diagnostic errors in pediatric stroke. So that's the one thing that makes me a little nervous. We at Children's Memorial Hermann have not switched over to TNK as opposed to TPA in kids, largely because I have dragged my feet on it because I'm nervous about that switch, and I'm waiting for more safety data from other centers first. So that's my opinion. I don't have any reason to think it's not particularly unsafe in children, except for that if a diagnostic error is made, you have less of a fallback to reverse your mistake with TNK than you do with TPA.
And I think that's a very interesting point you bring up, the administration side, where alteplase can just be, or is usually a push followed by an infusion, whereas
Right.
TNK is just a push. How do you approach a hemorrhagic conversion? Say it's a small hemorrhagic conversion. Do we need to do anything? Do we just watch it like in the adult side? Or if it's a meaningful hemorrhagic conversion, do you do the same protocol we use on the adult side to reverse the medication?
That's a good question. So thankfully, I've yet to have a hemorrhagic conversion in a kid with thrombolysis. I hope it stays that way. We don't do it very often. If I was in that situation, I would just follow what I would do on the adult side. Kids are actually probably the tiniest bit clottier than some adults, or some people think they might be. So that's why I'd say you can just leave it alone, and we do the same things we do with adults. But as of yet, cross my heart and hope to die, we've haven't had that complication in a child. And I hope we never do.
Yeah, same. I hope it never does happen, but
Yeah.
Prepare for the worst, hope for the best.
Right.
So
Right.
And then a couple more questions before we're done. What's your opinion on endovascular approaches to pediatric stroke?
Awesome.
Any specific post endovascular care tips that you can give us, or anything that you would like for us to know?
Awesome question. So, man, what a great question. So, in terms of taking them for endovascular for hopefully a thrombectomy, what I tell people is, if you would do it in an adult, based on their imaging profile, and you have the anesthesia and ICU support to care for them during the procedure, you should do it in a kid, as long as your interventionalist feels comfortable. There's a couple considerations for pediatric thrombectomy that you have to think about. So one is the best intervention candidates we've run into have all been cardioembolic candidates, and I think that's similar experience at other places. So congenital heart disease patients are often good candidates if you can recognize it fast enough. And we've had cases where I've been very happy with how the children have done. But you do have to, your interventionalist is going to have to call the surgeon before they take them. And the pediatric heart surgeons are always willing to talk to you. You don't have to worry about them wanting to save that kid's brain. They will want to, I promise, just to make sure you understand their anatomy before you go in, because typically they won't have a normal aortic system, or it may have been reconstructed, or they may have a heart with just one ventricle, and that's important to know. So those are great candidates.
That's actually a good point you make, because that's not something I had thought about, reaching out to the CV surgeons or the CT surgeons, just to make sure you get their opinion.
Yeah, absolutely. It's really important to call the CT surgeon for these congenital heart disease cases. Now, we've had someone transferred to us where the endovascular person was taking a teenager who only had one ventricle at an outside institution. He couldn't reach the CV surgeon in time, and he just went for it and probably saved her life. And because of how, so we know what bad outcomes will come from, like a proximal left MCA occlusion or a basilar artery occlusion. And so for those, sometimes you just have to go for it. But if you can, try to reach for a cardiologist or CV surgeon or whoever.
That's
one
consideration. You make a great point, and it's something that's well noted, and I'll take it to heart, to be honest.
Yes. Thank you.
Piggybacking off Dr. Grata and Dr. Zapp a little bit, do you think there's going to be a role for MSU, the mobile stroke unit, at some point in pediatric stroke?
That is a great question. They have, of course, it has popped up over coffee talks with both of them. And I think that pediatric stroke is, like I said, it's not a rare disease, but it is an uncommon disease. And I think there is a role for specialized pediatric transport units. There might even one day be a role for specialized pediatric neurocritical care-esque transport units. But the diagnostic dilemma and the amount of information you need about someone with pediatric stroke prior to thrombolytic administration probably, and the infrequency with which it happens, probably means that in the future, I think it would be difficult, and I'll just go ahead, and hopefully if I get proved wrong, that's great, but I think would be unlikely, we'd be unlikely to ever have a pediatric mobile stroke unit.
Understood, and that makes a lot of sense. And a couple more questions, I promise, before we have you go about your day.
Okay.
But, any specific case that you remember that has just been with you throughout your career that illustrates the possibilities of stroke care in kids, or any case that you would like to let us know about?
Oh gosh. So we talked a lot about what to do with that acute care stuff, and that for children with heart disease, you have to call the surgeons, and of course you have to be careful with suspected arteriopathies and endovascular care in kids, because of it might be inflammatory or moya. You just have to be careful once the catheter goes up there. I think that I usually, when I got into this, when I was a medical student, I really wanted to be a stroke neurologist. And when I did my pediatrics rotation, I realized that I'm happier working with kids, and I thought I couldn't be a stroke neurologist anymore, and that's okay. But we found a way to make it work. Initially, I was drawn to it because I just liked the idea of having to make decisions fast to help people, and all that, hotshot stuff that stroke neurologists have a stereotype for. As I set up clinic and started following these kids longitudinally, I think what got me is that even though they recover better than adults, quote unquote, children with stroke have a lot of problems for the rest of their lives. And sometimes we refer to them as the walking wounded because they'll look pretty good, but there's mental issues that happen. There's issues with depression and mobility that can get in the way of what they want to do. And I'm motivated by just trying to find a way to help these kids live the best life that they can with the science that we have around. So I think recently, I won't name any names, but we had set up this brief rehabilitation trial where we were trying to restore some arm function in kids, and this one girl finished, and she had a pretty big stroke and has some significant weakness. And she asked if we'd be able to do it again, or if there's any more studies coming up. And I said, well, actually, yeah, we're planning to move forward starting next summer with more work, and hopefully we'll find ways to help you and kids like you in the future. And I said that, and then she stuck her hands up. I mean, the right one as best as she could, and went, yes, amazing, and like high-fived her dad. And I think being for them in the hospital is fantastic. In addition, forming those relationships long term, where you can be with someone and help them to the best of your ability as they go on the rest of their life after their stroke can be really, really meaningful. And I think that interaction, which was a couple of weeks ago, really stuck with me. And that's the kind of thing that motivates me, at least, to keep going and keep trying to find ways to help them in whatever way we can.
Thank you for sharing that with us. It's definitely something that we should consider when seeing these patients, even though we more than likely won't be seeing them in clinic. I mean, it's something that we should look forward to. And finally, what takeaway would you like for our audience to have? If there's one thing they could, if there's one thing they could take away from this, or if they fast forward all the way to the end, what would you like for them to know?
Okay. All right, here we go. So stroke neurologists, stroke trainees, all my adult neurology colleagues, here's what I'm going to tell you about pediatric stroke if you had to take just one thing home. It's that it does happen. If you get a consult for concern for that, treat it seriously, just like you do with your adult code strokes, and you can fall back on that training with just a couple of different little caveats to change it, which is one, the biggest thing you're trying to do is diagnose large artery occlusion or an intracranial hemorrhage. And so if you don't have access to an immediate MRI, you can do that with a CTA and a CT. And if you find that they are not having those things, then you did what you needed to do, and you can transfer them on to the nearest tertiary care children's center as urgently as you can, and feel confident that you were doing the right thing.
Wonderful. Thank you so much for that. I do want to say thank you so much for this, because even if I am still nervous with taking care of pediatric patients, I think I might have an idea of what to do now, at least in the acute setting. And again, thank you for just helping us out and being a part of this. I also want to say thank you. During my residency, Dr. Daniel Davila over at TCH was also a great help. And that's just, again, because pediatric patients make us so nervous. But both you and him and the pediatric stroke specialists that I've known have been very, very helpful, and have gone through us and helped us out a lot. That's basically just thank you.
Absolutely, and I'm sure Dr. Davila would appreciate that. I can't say enough good things about the work him and his colleagues do, and we're always happy to collaborate with our friends at other institutions. So thank you for bringing that up.
Wonderful, and happy holidays.
Yeah, you as well. Thanks, Carlos.
Thank you.
And that's going to do it. We are wrapping up another enlightening episode of Stroke Busters. A massive thank you to our incredible guest, Dr. Stuart Fraser, for sharing your expertise and insights on pediatric stroke. Your work is truly inspiring. And a special shout out to our listeners. Thank you for tuning in. Your curiosity and engagement make this podcast possible. Before we go, a huge thanks to our host, Carlos de la Garza, for guiding today's conversation with thoughtful and insightful questions. Your dedication to bringing impactful discussions to our audience was truly commendable. And as always, ideas and opinions expressed on this podcast are our own and are not a substitute for expert medical advice. Always contact your doctor before starting any program or therapy to make sure you're getting the best care tailored to your unique situation. If you enjoyed today's episode and want to stay updated on all things Stroke Busters, be sure to follow us on social media. Follow us on LinkedIn, Instagram, Facebook, and X at UT Health Stroke to stay updated on upcoming episodes and share with colleagues, friends, and family. For updates and the latest news on the Stroke Institute, research, programs, events, and more, go online to uth.edu/stroke-institute. Don't forget to subscribe on Spotify, Apple Podcasts, or wherever you listen to your podcasts. Hit that follow button. Never miss an episode. We have some exciting discussions lined up for you in 2024. So stay informed, stay curious, and stay engaged. Thank you for being part of the Stroke Busters community. Until next time, take care.